Good afternoon, everyone. Let's just wait for the rest to join before we start, huh?
Yes, Doc.
Yes, Doc. I already
Okay,
texted.
thank you. Sige, I think we can start. Let the others catch up na lang, ha?
Yes, ma'am.
Okay. Let's start our afternoon with a prayer first. So, Heavenly Father, thank you that despite the circumstances, we have the means to congregate virtually in the pursuit of knowledge. Please send forth your Holy Spirit of wisdom and understanding. May everything we do begin with your inspiration and continue with your grace. Amen. Can you hear me, Ra? Can you hear me well?
Yes, ma'am.
Yes, Doc.
Okay, sige. So before anything else, hello, good afternoon. My name is Dr. Debbie Tan Engsi. I'm a nephrologist. I know you had your lecture with Dr. Revillas this morning on fluids and electrolytes. So I'm sure you learned a lot. Let me just first introduce myself briefly. I studied medicine at Cebu Institute of Medicine and then went on to have my medical residency training at Chongmo Hospital before training under nephrology at National Kidney and Transplant Institute. So Dr. Villas is a very good friend of mine. She was a group mate back in medicine and my roommate in QC at NKTI. So I hope you can learn something from our lecture this afternoon. First, we have our topic outline. So we will be discussing first an acid-base physiology very briefly, and then go through the steps of ABG interpretation before going through each primary disorder, but we will be focusing more on the metabolic acid-base disturbances. Okay, so acid-base regulation is simply the maintenance of a normal hydrogen ion concentration. Let's start off by defining some terms. Okay, so an acid donates a hydrogen ion and a base accepts it. In this equation here, HA is your undissociated acid, whereas your A is your dissociated base. So hydrogen ion is given off by the acid and the base accepts it. The following are examples of your acids and their conjugate bases. So you have your carbonic acid, it gives off hydrogen ions as well as its base, the bicarbonate. And then dihydrogen phosphate gives off hydrogen ions and your hydrogen phosphate. So you might be wondering why all the fuss about hydrogen ions. This is because if their concentration rises, your hydrogen ions will bind to intracellular proteins. And when that happens, it can alter the charge of the protein, the shape of the protein, and even its function with dire consequences in our body. So some more terms, acidemia, when we speak of acidemia, it's an increase in hydrogen ions or a decrease in pH to less than 7.4. Whereas acidosis is a process that tends to raise your hydrogen ion or to decrease your pH. Alkalemia is a decrease in hydrogen ions or an increase in pH to more than 7.4, whereas alkalosis is a process that causes alkalemia. So acidosis causes acidemia, alkalosis causes alkalemia. Since we know that pH is a negative logarithm of your hydrogen ion concentration, and a rise in hydrogen ion leads to a reduction in pH. Okay, we already know that. So arterial systemic pH is normally maintained at 7.35 to 7.45. And this is accomplished by three general mechanisms. First, we have chemical buffering. Buffers are like your body's hydrogen ion sponges, which serve as a first line of defense against drastic changes in pH. So the most important buffer system in our body quantitatively is your bicarbonate buffer system. Here, your hydrogen ion binds to bicarbonate, and then it forms carbonic acid. Carbonic acid immediately dissociates into carbon dioxide and water as catalyzed by your enzyme carbonic anhydrase. So we have other buffers in our body. It's not just bicarbonate. We have bone, we have phosphate, we have hemoglobin as well. Sorry. So next we have respiratory regulation. So the carbon dioxide that was formed from this equation will now be regulated by our lungs through ventilation. This occurs in a matter of minutes to hours. And lastly, control of bicarbonate levels by the kidneys, which takes hours to days to complete. So we have to understand that when our kidneys excrete acid, this is equivalent to generating new bicarbonate for the body. Okay, next, let's talk about the daily acid load. So you might be asking, why is there a need for all of these processes in our body? That's because every day from our diet and metabolism, we add about 50 to 100 millimoles per day, or that's about 1 millimole per kilogram body weight per day on a typical Western diet. So that means 50 to 100 milliequivalents of hydrogen ions need to be buffered each day. So remember this equation. The hydrogen here drives the bicarbonate buffer equation toward the production of water and carbon dioxide. The carbon dioxide is excreted by the lungs as mentioned, and the bicarbonate is lost because it's buffering your hydrogen ions. So your kidneys need to replace the lost bicarbonate. And this happens in the distal nephron. Okay, so let's talk about renal regulation briefly. So, the chemical buffering and respiratory compensation, they provide only a temporary relief from the changes in body pH, and they act quickly, which we need at the time. So it's a temporizing mechanism. However, it's our kidneys that provide the ultimate defense. First, it does this by absorbing virtually all of the bicarbonate in the filtrate that passes through the glomerulus. So this is done predominantly by our proximal tubule, with contributions from our loop of Henle and our distal nephron. So bicarbonate reabsorption is one way that the kidneys regulate bicarbonate levels, and the other way is by net acid excretion. So each milliequivalent of net acid excreted corresponds to 1 milliequivalent of bicarbonate returned to our extracellular fluids. So one of the ways it does this is by ammonium generation. So you will be hearing a lot about ammoniogenesis later in our lecture. So ammonia is produced by our proximal tubule cells, and then it travels in our loop of Henle where it gets reabsorbed in the medullary interstitium, and then it gets secreted into the distal nephron along the medullary collecting duct. So ammonia, NH3 here, binds to the hydrogen ions that are secreted in our distal nephron, and together they formed ammonium. So for each ammonium that is produced and excreted by our kidneys, bicarbonate is produced. Okay, so I hope this is clear. Next, pH is simply the ratio of a change in bicarbonate and or to PCO2, I mean. So changes in pH occurs because of a change in either or both. The relationship is illustrated wonderfully by our Henderson-Hasselbalch equation. So this equation is actually used if you have one lacking variable and you have the rest present. So this is what happens when we get an ABG, we actually compute for bicarbonate. So the values that come out, they're not all measured. What's measured is pH, PCO2, PO2, and then bicarbonate is generated or computed from those measured values. Now, these are our 4 primary acid-base disturbances caused by either a change in our bicarbonate or in our carbon dioxide. Now, acidemia can be due to either a low bicarbonate or a high PCO2, and alkalemia from a high bicarbonate or a low PCO2. Okay, so since pH is the ratio between our bicarbonate and PCO2, if we want to keep the pH constant, we need to keep the ratio constant. So that's why if one component changes, so this is our primary disturbance, the other must change as well in order to maintain a constant ratio. So first, if bicarbonate is decreased as a primary disturbance in metabolic acidosis, pH of course decreases, diba? Because the hydrogen ion increases. Now, our body compensates by increasing its alveolar ventilation in order to blow off the CO2, thus decreasing the PCO2, limiting the reduction in pH. However, if our bicarbonate increases as a primary disturbance, pH increases as a result, and our body compensates by decreasing alveolar ventilation in order to cause an increase in PCO2, limiting the rise in pH. So if you've noticed, for the metabolic acid-base disturbances, the direction of the primary change in bicarbonate is similar to the direction in the pH. So bicarbonate goes down, pH goes down. When it goes up, pH goes up. Okay, so that's the metabolic disorders. Let's move on to the respiratory ones. On the other hand, disturbances in alveolar ventilation induce changes in CO2 elimination and thus in PCO2. So when we have primary hypoventilation, this impairs CO2 elimination, producing an elevation in PCO2 and reducing the pH. This is called respiratory acidosis. And if we have a primary hyperventilation, PCO2 decreases and pH rises. Now, the kidneys can minimize changes in pH by varying the hydrogen ion excretion and bicarbonate reabsorption, as we've mentioned before. So, as you can see, as with the metabolic disorders, the compensatory response is in the same direction as the primary disturbance. However, for the respiratory disorders, the direction of change in your PCO2 is in the opposite direction of change in your pH. Okay? Sige, so now for the steps in acid-base diagnosis. Table 51-3 of Harrison's enumerates the steps in acid-base diagnosis. Wait lang, let me admit a few more people. Sige, it starts with obtaining ABG and electrolyte simultaneously and then comparing your bicarbonate on ABG with your total CO2 on the electrolyte panel to verify accuracy. However, even before anything else, a careful history taking and physical exam is important in order to obtain diagnostic clues from the clinical setting. So this allows you to interpret values with context because you are able to treat your patient and not just lab results. Okay. So your calculated bicarbonate on ABG must agree within 2 millimoles per liter with a total carbon dioxide on your electrolyte panel. And if this isn't so, you must consider either a lab error or that they were not drawn simultaneously. So why is this important? Now, accurate acid-base diagnosis requires an accurate anion gap computation. And to determine the anion gap, you need an electrolyte panel that's accurate and drawn simultaneously. Otherwise, your diagnosis will not be right. So let me emphasize that if you plan on getting an ABG in your patient, be sure to order a serum chloride and a total CO2 among others. So this is often forgotten, no? Or missed out. You will never be faulted by your resident or your consultant if you request for a serum chloride in a patient whom you suspect to have an acid-base disturbance. So this is important, your serum chloride, for your anion gap determination later on. Okay. So first, let's get ourselves acquainted with the normal ABG values. There's a range of normal values for each parameter, but we are often using the midpoint as our normal value for the coming equations. So pH 7.35 to 7.45, PCO2 35 to 45, bicarbonate 22 to 26, okay? Next, determine the primary disorder. First, let's start with looking at the pH. Is it less than 7.4? If so, we have an acidemia. If it's more than 7.4, we have an alkalemia. Next, we look at bicarbonate and PCO2. So if we have an acidemia, you check if your bicarbonate is less than 24. If so, it's metabolic acidosis. If your PCO2 is more than 40, then it's a respiratory cause of the acidemia. And with alkalemia, you also check bicarbonate and PCO2, a high bicarbonate metabolic alkalosis and a low PCO2 respiratory alkalosis. Okay, so let's have some examples. First, we have a 33-year-old female with thyrotoxicosis and pneumonia. She is underweight, hypotensive, tachycardic, tachypnic, and febrile. She's been passing watery stool 3 times since admission. So first, let's look at our patient. She is hypermetabolic and septic, and she's been having diarrhea. Now, let's look at pH. It is 7.15. So we have an acidemia, right? Next, is the PCO2 the primary change that could have caused the acidemia? PCO2 is 15. No, right? It's not because it's less than 40. But the bicarbonate is low. It's 5. So this is the primary disorder, is metabolic acidosis. Okay, so the metabolic acidosis here could be caused by either the diarrhea or even the sepsis, or the lactic acidosis, So next, we have a 32-year-old female with severe vomiting due to viral gastroenteritis for 3 days. She develops anorexia, and on PE, she has signs of volume depletion because she has orthostatic hypotension, she has flat neck veins, dry skin, and oral mucosa. So let's look at the pH. It's 7.5. So we have an alkalemia. And is our PCO2 the primary disturbance? No, right? But our bicarbonate is, because it is more than 24. So we have here as a primary disorder a metabolic alkalosis. The metabolic alkalosis is due to the vomiting and the volume depletion, but we will be discussing that later. Next, we have a 54-year-old male with a history of COPD and a 2-day history of sputum production and shortness of breath. So he has a pneumonia as well. Our pH is 7.25, telling us we have an acidemia. And our PCO2 is 70, which is more than 40. This is a respiratory acidosis, right? Okay, the respiratory acidosis could either be chronic from the COPD or it could even have an acute component because of the pneumonia. Lastly, we have a 5-year-old in a stuporous condition. He was seen with a bottle of aspirin tablets earlier that day. So our pH is 7.48, telling us that this is an alkalemia. And then our PCO2 is less than 40, telling us that this is a respiratory alkalosis. So I hope that was clear. Did everyone get that? Later, we will discuss about how actually, I can tell you now that aspirin tablets cause respiratory alkalosis because it directly stimulates our respiratory center in the brain. Okay, so next, let's estimate the compensatory response to determine if we have a simple or a mixed acid-base disorder. So if the compensation is as expected, we might only have one acid-base disorder present or a simple disorder. However, if it's too high or too low than expected, then another disturbance could be present. So you can estimate using formulas like here and the acid-base nomogram. First, the formulas. So the most commonly used formula for metabolic acidosis is the Winter's equation. So yes, it has a name. It's the level of bicarbonate times 1.5 plus 8 and plus minus 2. Next, for metabolic alkalosis, let's take the first formula on the table. So I just made it easier to remember, no, 0.75 here, I just made it into 3/4. And then since this only describes the relationship of change between PCO2 and bicarbonate, let's make it into a formula that gives us the absolute value. So 3/4 of the delta bicarbonate means a change in bicarbonate, plus 40. Why 40? 40 is the normal PCO2 level. Okay, so let's take one example. We have bicarbonate of 36. To get our delta bicarbonate, we have to subtract 24, which is the normal bicarbonate, from 36, and we get 12. Now, 3/4 of 12, and then you add 40, which is the normal PCO2 level, you get an expected PCO of 49, PCO2 of 49. Okay, so that's how we use our formulas. Next, okay. So if in metabolic acidosis and alkalosis, your PCO2 is higher than predicted, then we have a concurrent respiratory acidosis present. However, if it's too low, then we have a respiratory alkalosis. Here are sample values on the table 51-2 on Harrison. So we have a patient with lactic acidosis and sepsis in the ICU with the following lab results. So at first glance, you know that your ABG is abnormal, even if you have a pH that is within the normal range, because your bicarbonate and your PCO2 are both deranged. So since your pH is less than 7.4, it's an acidemia. Now let's take a look at your PCO2. Could this be the primary disturbance? No, because it's less than 40, but our bicarbonate is less than 24. So this is a metabolic acidosis, okay? So using our Winter's equation, let's substitute the bicarbonate here with 14, which is our patient's value, 40 times 1.5 plus 8 plus minus 2. We get a expected range of 27 to 31. Our patient's PCO2 is 24, which is much less or lower than expected. So this patient has metabolic acidosis and a concurrent respiratory alkalosis. The metabolic acidosis can be explained by the lactic acidosis, and respiratory alkalosis is seen in patients with sepsis. Okay. Next, we have a COPD patient on diuretics. When you see here, look at the labs. When you see a chloride value, this is low, okay? 88 is low because the normal value is 96 to 106. When you see a low chloride value and a high bicarbonate value, that's either metabolic alkalosis or a respiratory acidosis. And how do you distinguish between the two? You check your pH. So your pH is 7.42. This is an alkalemia. Okay, so what's causing the alkalemia? Look at your PCO2. No, because your PCO2 is more than 40, but your bicarbonate is high. So this is a metabolic alkalosis primarily. Let's solve for our expected PCO2. So our delta bicarbonate is 42, the patient's value, minus 24, the normal bicarbonate, multiply it by 3/4, and then add 40, which is the normal PCO2. And you get an expected value of around 53.5. So our patient's PCO2 is 67, which is much higher than expected. So we have a patient with metabolic alkalosis and a respiratory acidosis. So the alkalosis is due to the diuretics. I mean, the metabolic alkalosis is due to diuretic use, and the respiratory acidosis is from the COPD. Okay. Sige. So was that all clear? Let's move on to the respiratory disorders. So the table on the left it just makes the table on the right easier to remember. Okay, so just make a 3x3 table. You label acute, chronic on the side, and on top it's respiratory acidosis and respiratory alkalosis. Just remember it goes left to right, top to bottom, alphabetically. And then you write down 10 and with a colon in each of the 4 boxes. And then you write, this is what you're going to memorize. 1, 2, 4, 4. It goes left, right, top, and bottom. So I'm basically just making the table on the right, which is in Harrison's, much easier to remember. Because here in Harrison's, it speaks of 0.1 change for every 1. So we're just removing all the decimal points so it's easier to remember. Instead of per 1 mmHg change in PCO2, we're making it 10 so that we get whole numbers for the change in bicarbonate, okay? So anyway, knowing that relationship, so it just says for each 10 mmHg change in PCO2, either an increase or a decrease, you're expecting a blank number of change in your bicarbonate level. So knowing that relationship, let's derive this formula. For acute respiratory acidosis, you subtract the normal PCO2 level from your patient's PCO2. So PCO2 minus 40, and you divide by 10 because we're speaking of per 10 mmHg change, and then you multiply it by either 1 for acute and 4 for chronic, okay? And then of course we don't stop there. We have to add it to the normal bicarbonate level of 24. So you get an absolute number. Okay, so that was acidosis. Let's talk of respiratory alkalosis. So instead of PCO2 minus 40, we're going to make it 40 minus PCO2 because in alkalosis, respiratory alkalosis, the patient's PCO2 is lower than 40. So divide by 10 and multiply it by 2 or 4, depending if it's acute or chronic, and then add 24, which is the normal bicarbonate level. And that is your expected bicarbonate level. Okay. So if the patient's bicarbonate is lower than expected, that is a metabolic acidosis as well. And if the bicarbonate is too high, then the patient also has a metabolic alkalosis. So you might be wondering, why is there an acute and chronic respiratory acidosis and alkalosis? So that is because the renal response takes time. In acute respiratory acidosis or alkalosis, our buffers are our only protection. So that's why, as you can see here, the change in bicarbonate is only like 1, 2, but when it becomes chronic, the change now is 4 for each 10 mmHg change. So that is because in chronic respiratory acidosis and alkalosis, which is completed in around 2 to 5 days, the kidneys have already completed its compensation by either secreting the hydrogen if it's too much or decreasing the renal hydrogen secretion. Okay, so how do you determine if this is an acute or chronic respiratory problem? You're going to have to decide based on the patient's history and physical exam. So for example, in acute respiratory acidosis, you can have a patient with an acute exacerbation of asthma or following cardiac arrest or drug overdose. So in these cases, you're able to see the patient soon after the inciting event that has caused the respiratory acidosis. However, in chronic respiratory acidosis, usually the most common cause is COPD, and we have patients who are obese and are hypoventilating because of that. Okay. Sige, so let's have a few more examples. A 65-year-old male with a history of coronary artery disease is admitted for difficulty breathing for a few hours prior and a decreasing urine output. So the decreasing urine output tells us this patient probably has some form of acute renal failure, and Knowing that he has a coronary artery disease and difficulty breathing tells us maybe this patient is having a pulmonary congestion, or it could also be a pulmonary infection. So let's look at our pH. It's 7.23. This is an acidemia, and it's because our PCO2 is high, it's 50. So we have an acute respiratory acidosis because he just started having difficulty in breathing a few hours prior. So we use this formula and substituting the values, we have a 50, our patient's PCO2 minus 40, which is the normal PCO2 divided by 10 times 1 because it's acute, plus 24, we get 25 as our expected bicarb. However, our patient's bicarbonate is only 18, telling us that this patient has an acute respiratory acidosis and a metabolic acidosis. So the respiratory acidosis, it could be from, as I said, pulmonary congestion, pneumonia, anything that's causing hypoxia. The metabolic acidosis could be from the renal failure. Okay. Sige. So next, remember that 5-year-old child in stuporous condition that was seen playing with a bottle of aspirin? Well, he has another problem. Because aside from acute respiratory alkalosis, if we solve for the expected bicarbonate, so that's 40 minus 20 divided by 10 times 2 plus 24, it's 28. But our patient's bicarbonate is only 16. So he has an acute respiratory alkalosis and metabolic acidosis. So these two go hand in hand in salicylate poisoning, okay? Which we will be discussing later. So that's it for the formulas. Another way to determine if the response in bicarb or PCO2 are appropriate is this acid-base nomogram. When you plot the values and when they fall within the shaded areas here, then it's possible that you might be dealing with a simple acid-base disturbance. I say possible because it does not necessarily rule out your mixed acid-base disorder because your ABG values could impose on one another, and then it might even come out as normal when in fact when you look at your patient, he's so sick. So that's why it's best if you use your formulas and not just this more convenient option. Okay. Sige. Next step, always calculate the anion gap even when at face value you don't seem to have a metabolic acidosis, because at times this is how your high anion gap acidosis is discovered. And also, in order to diagnose your mixed acid-base disturbances, you need the consideration of your anion gap. To understand the concept of the anion gap, you must recognize first that our plasma is an electroneutral solution, which means that the positive charge always balances out the negative charge and vice versa. So this is the formula for the anion gap. Serum sodium minus the sum of your chloride and your bicarbonate level. Now, sodium here represents our plasma cations, while chloride and bicarbonate represent your plasma anions. Of course, they're not the only cations and anions in our body, but we are using them because they are the major, they contribute to that, to the cation, to the anion component in our plasma. So as you can see, the sodium level exceeds the sum of our chloride and bicarbonate by roughly 6 to 12 millimoles per liter. So this is our anion gap. An increase in anion gap, meaning if it's more than 12, tells us that there is an increase in the concentration of anions that are not chloride and bicarbonate. So these can be albumin, we have phosphates and sulfates, which are inorganic acids, and also organic acids. Now, it's not always 6 to 12 millimoles per liter, that's the normal anion gap, because for each laboratory, there is difference in chemical analyzers used. So it's best if the laboratory itself, they identify their normal range for this. Okay. So here, let's take a look at letter C. So this is what I meant kanina when I said that sodium makes up the most of the body's cations or the plasma cations, whereas chloride and bicarbonate makes up majority of our anions. But we have here some other cations that we are not considering in our formula. We will call them unmeasured cations, but they are made up of calcium, magnesium, potassium, among others. So it does not mean that we cannot measure them. We are just not considering them in our formula. So same is true for our unmeasured anions, okay? Sige, so therefore, to derive the anion gap, we can either subtract chloride and bicarbonate from sodium, which we already discussed, or we can just subtract our all unmeasured cations from the unmeasured anions, and we get our anion gap. Okay, so this formulation indicates that the anion gap will increase if your unmeasured anions increase or if your unmeasured cations decrease. So what do we mean by decrease in unmeasured cations? If you have a patient with a calcemia or hypomagnesemia, this can cause an increase in your anion gap. Okay, but the most common cause of an increase in anion gap is usually an increase in unmeasured anions, which we will discuss later. So here, we can also have a decrease in anion gap. This occurs if our unmeasured cations increase. So our patients here are hypercalcemic, hypermagnesemic, or if our patient has an addition of abnormal cations in the blood, in the case of lithium toxicity, which is a cation, and in multiple myeloma, in which there are abnormal immunoglobulins in our plasma, and these are cations as well. A reduction in plasma albumin, such as in liver disease or nephrotic syndrome, can cause a decrease in anion gap because albumin makes up a huge portion of our anion gap. And lastly, hyperviscosity and severe hyperlipidemia causes a lab error in which our serum sodium levels are underestimated. So this is actually a false decrease in anion gap, whereas the first three are true reductions in anion gap. Okay, so let's calculate the anion gap. We have a 50-year-old male with the following lab results. So sodium 140 minus chloride, which is 105, plus 15, which is bicarbonate, and you get a value of 20. So the patient has a high anion gap because it's more than 6 to 12. So for the remainder of our lecture, let's set the normal anion gap as 10. Okay, that's the same in our book in Harrison's. So in normal individuals, the major unmeasured anion responsible for the existence of the anion gap is albumin. So as a result, if you have a patient with hypoalbuminemia, you would have to adjust downward the expected baseline value of your anion gap. So for each gram per deciliter of serum albumin below the normal value of 4.5, 2.5 millimoles per liter should be added to the reported anion gap. So let's use this formula. Corrected anion gap is equal to 4.5, which is our normal albumin, minus the patient's given albumin level, times 2.5, because that's the relationship, 2.5 here, plus the measured anion gap, the uncorrected anion gap of your patient. Okay, so let's take this example. We have an albumin level of 2.5 and an uncorrected anion gap of 20. So we will just need to subtract 2.5 from 4.5, which is normal albumin, multiply that by 2.5, and add 20, the uncorrected anion gap, and we get 25 millimoles per liter, which is our corrected anion gap. Okay. Sige, so now that we know what the anion gap is all about, let's proceed with the high gap acidosis and the non-gap acidosis. Now, metabolic acidosis can be due to the loss of bicarbonate, either in diarrhea or renal tubular acidosis, which we will discuss later. So see here, when you lose bicarbonate, so from this to this, it has reduced. To maintain electroneutrality, your chloride increases. Okay, so when this happens, your anion gap remains normal. It remains the same. That's why it is called a non-gap or hyperchloremic metabolic acidosis, because your chloride increases to maintain electroneutrality when your bicarbonate is lost. Okay. Now, metabolic acidosis is also caused by an addition of an acid. So look here, your anion gap is this small, and then it becomes this when you add some acid in your plasma. Now, this causes a decrease in your bicarbonate because your bicarbonate buffers the acids, as we've mentioned. And because the addition of the acid has already maintained the electroneutrality, our chloride levels do not need to increase. So this is a high gap acidosis, and one of the more common causes is lactic acidosis in tissue hypoperfusion. Okay, I hope that's clear. Now, our sixth step, we're still in the steps of ABG interpretation, is to know the four causes of high GAP acidosis. We have ketoacidosis, which results from uncontrolled diabetes or in association with chronic alcohol abuse. We have lactic acidosis in tissue hypoperfusion. Patients with kidney failure may develop a high anion gap acidosis because of retention of hydrogen ions and inorganic acids. And then lastly, we have toxins. Now, these alcohols are metabolized into organic acids, like so ethylene glycol into glycolic and oxalic acid, methanol to formic acid, and salicylates to lactic acid and ketoacids. But we will be discussing that later. Next, know the two causes of non-GAP acidosis. The more common ones are diarrhea and renal tubular acidosis. Okay, so this is a useful mnemonic for the causes of GAP acidosis. Gold mark. So G is for glycols, O oxoproline, L lactate, D lactate, methanol, aspirin, renal injury, and ketoacidosis. We will briefly tackle each one on the next part of this lecture. Okay, so step number 7, compare the anion gap, the delta anion gap, and the delta bicarbonate, or the delta-delta for patients who were identified to have high anion gap acidosis. Okay, so the magnitude of the increase in anion gap should be compared to the magnitude of decrease of your bicarbonate, because in a pure anion gap acidosis, 1 milliequivalent of acid added to the plasma is buffered by 1 milliequivalent of bicarbonate. So that's why usually they should be 1:1. Okay, so how do you get a delta anion gap? Your patient's anion gap, you subtract 10 from it, because 10 is our ideal anion gap as mentioned. Now, to get the delta bicarbonate, you subtract your patient's bicarbonate from the normal bicarbonate level of 24. Okay, so however, if your patient has a concomitant metabolic alkalosis or a concomitant non-GAP acidosis, then you might get a delta-delta that's not 1, but is more than 2 or less than 1, respectively. So let's discuss how that happens again. So when you have a delta-delta that's less than 1, which means that he has a non-GAP acidosis present along with a high GAP acidosis, that means if it's less than 1, that means your denominator is higher than your numerator, right? So your denominator is delta bicarbonate. So if your delta bicarbonate is greater, that means that the reduction in bicarbonate in your patient is much larger than expected for the rise in anion gap. So it means your patient's bicarbonate level is lower, much lower than the anion gap. So the most usual cause in an ongoing non-GAP acidosis along with a high GAP acidosis occurs in a patient with diarrhea. So, example, the patient has diarrhea and that causes a non-GAP acidosis. However, then the diarrhea is so severe that it has resulted into hypovolemia. The hypovolemia causes tissue hypoperfusion and thus lactic acidosis. So that's how this happens. That's how you can get a high GAP and a non-GAP acidosis as well. Now, when your delta-delta is more than 2, that means that your denominator is much less than your numerator, which means that your patient's bicarbonate is not that different from the ideal bicarbonate. So I hope you understand. The patient's bicarbonate level is probably just 20 and the normal is 24. So that's why when you subtract 20 from 24, you just get a value of 4, right? So the reduction in bicarbonate here is much less than the expected bicarbonate as compared to the rise in your anion gap. So it usually tells us that the patient has a high GAP acidosis and a metabolic alkalosis. And this can be seen in patients who have end-stage renal disease. So they are uremic and they vomit. The vomiting causes the metabolic alkalosis. So anyway, don't worry, we will discuss on metabolic alkalosis later. Okay, so I hope this is clear. So again, this is the formula, an anion gap minus 10 over 24 minus bicarbonate. As an example, an anion gap of 20 and a bicarbonate level of 20. So 20 here, the patient's anion gap, minus 10, which is the normal anion gap. 24, the normal bicarbonate, minus 20, the patient's bicarbonate. You get 10 over 4 or 2.5. So this is what I said. Your patient has a metabolic alkalosis as well as a high gap acidosis. Okay, let's take the example cited in Harrison's about the alcoholic who has been vomiting. So the patient now has a metabolic alkalosis. Look at the ABG because of the vomiting. Now, if this patient develops a superimposed alcoholic ketoacidosis, his pH from 7.55 now becomes 7.4. His PCO2 from 47 now becomes 40. And bicarbonate of 40 now becomes 25. So what can you observe? This looks like a normal ABG, right? And if you had just gotten an ABG at this point, you would even say this patient has a normal acid-base balance. However, that is why it is important to look at your patient first, know the history and PE, and obtain diagnostic clues, because you would not take this normal ABG values at face level if you see your patient is not at all well. Okay. So here, the patient has, so diba, it looks normal, your ABG. But when you solve for your anion gap, you get a value of 30. That's 135 minus a chloride of 80 minus bicarbonate of 25. So this is what I said about always calculating your anion gap, even if it doesn't seem like you have a metabolic acidosis, because it is at this point that you see the patient has a high gap acidosis, and when you compute for the delta, you have a value of 20, which is much more than 2. So your patient has a metabolic alkalosis and a high gap acidosis. The alkalosis is from the vomiting, and the high gap acidosis is from the alcoholic ketoacidosis. Okay, so let's bring back the acid-base nomogram. If you plot 7.4, 40, and 25, you would be right smack in the middle of this nomogram. That's why it is really best to use your formulas instead of this nomogram, okay? And the 8th step, actually, you can do this at any point of your ABG interpretation, is to compare the change in your chloride with your change in sodium. Now, changes in sodium occur as a result of changes in hydration, as I'm sure Dr. Revillas has mentioned this morning, whereas changes in chloride are due to changes for 2 reasons: in hydration or in acid-base balance. Okay, as you may recall, chloride increases in patients with non-gap acidosis, diba? And an elevated chloride can also be found in patients with respiratory alkalosis, because in these patients, respiratory alkalotic patients, the kidneys compensate by decreasing bicarbonate. And so the chloride level rises. So how do you distinguish between the two? You look at your pH. So just similarly, when you have a decrease in chloride, you look at either a metabolic alkalosis or a respiratory acidosis, in which the kidneys are compensating for the respiratory acidosis. Okay, so we have a patient with a history of vomiting and volume depletion. You see that both his sodium and chloride are decreased. However, if you compare the degree of reduction, the decrease in chloride is much greater than the decrease in your sodium, telling you that the patient not only has a problem with hydration, there is also an acid-base disturbance as well. Okay. Sige, so let's review the steps and answer a few practice cases in the next part of our lecture. First, obtain diagnostic clues. Next, obtain simultaneous ABG and electrolyte panel. Determine first the primary disorder by looking first at the pH and then your bicarbonate and PCO2. Check the compensatory response with the use of our formulas. Always calculate the anion gap. For a high gap acidosis, use the delta-delta equation and compare the change in chloride with the change in sodium. Okay, so metabolic acidosis is characterized by a low bicarbonate and a low pH, and after respiratory compensation, the PCO2 is also low. Now, the following cause metabolic acidosis as enumerated in Harrison. So generally, this disturbance occurs by one of two mechanisms, either a loss of bicarbonate or a gain or addition of acid. In an effort to excrete the CO2 as a compensatory response to the increasing hydrogen ion concentration, there is an increase in ventilation known as the Kussmaul respiration. So this is more an increase in tidal volume as opposed to an increase in RR. So the patient has deep breaths. So I think that you know how cosmal respiration looks like, and the rest are also expected clinical manifestations of metabolic acidosis. So these are the effects when I told you that when your hydrogen ions, they bind to your intracellular proteins and they cause dire consequences in the body. These are some of them, okay? Now, knowing the four principal causes of a high gap acidosis should guide your approach in the patients with these conditions. So you should ask, are there any conditions in this patient that could lead to tissue hypoxia that could cause lactic acidosis? Or does this patient have a diabetes that's poorly controlled? Is he an alcoholic? Or is there a coexistent respiratory alkalosis in this patient that's consistent with toxin ingestion, such as salicylate abuse? Or are there oxalate crystals in the urine, which is seen in ethylene glycol toxicity? And of course, always check your serum creatinine and BUN because you might be dealing with a patient with a renal failure causing the high gap acidosis. Okay, for our first case, we have a 60-year-old male brought to the ER for changes in sensorium that were noted 2 hours prior to admission. Significant history reveals the patient has been depressed and has been suicidal since his father and brother died. Now, at the ER, the patient is confused, appears intoxicated, has difficulty following simple commands, but has otherwise normal vital signs. PE is generally unremarkable except for a depressed mental status. Now, these are the patient's lab results. So let's say we've ruled out any organic brain lesions and we're narrowing it down to a metabolic cause. So we have low bicarbonate, a very high osmolality, and an ABG picture that looks like this. And what's this? These are oxalate crystals in our urine. Okay. First, diagnostic clues. Acute neurologic change in an elderly man with a history of depression and suicidal tendencies who was left unattended for around 6 hours prior to this when he was found delirious. Let's look at the bicarbonate on the ABG. It's ABG, so it's 17. Let's compare it to the bicarbonate on the electrolyte panel, it's 17. So you can probably say these two were taken simultaneously and there was probably no lab error. Now let's determine the primary disorder, which is our next step. Okay, so we have a pH of 7.28, that is an acidemia, and our bicarbonate is 17, so we have a metabolic acidosis. Let's apply the Winter's equation. Our expected PCO2 would be 1.5 times the patient's bicarbonate, which is 17, plus 8 plus minus 2. We get a value of 31.5 to 35.5. Now our patient's PCO2 falls within that range. So we could say the patient probably has a simple metabolic acidosis. Now let's compute for the anion gap. First, look at the patient's albumin. It is thankfully normal, so we don't have to correct this. Sodium is 141 minus chloride of 101 plus bicarbonate of 17. We get 23. This is a high gap acidosis. Next, for all high gap acidosis, we have to apply the delta-delta formula. 23 is our patient's anion gap, minus 10, the normal anion gap, divided by 24, the normal bicarbonate level, minus the patient's bicarbonate of 17. We get 1.85. So please compute with me so we can check maybe if there's something wrong with the formulas or equations, okay? Now, let's recall the 4 fundamental causes of high gap acidosis. First, lactic acidosis. There are no apparent causes of tissue hypoxia in this patient. However, as you will learn later, it's not always tissue hypoxia that leads to lactic acidosis. So this cannot be ruled out completely at this point. Next, on further history, our patient is not diabetic, has normal glucose on admission, actually 101, and hasn't been starving himself before admission. And he's also not abusing alcohol. So it's probably not a ketoacidosis. Next, let's look at the patient's creatinine and BUN. They're both normal. This is probably not renal failure causing the high gap acidosis. Finally, toxin ingestion is highly probable in this case. So let me introduce another concept. We have the osmolar gap. It is the difference between your measured and your computed plasma osmolality. So how do you compute for your plasma osmolality? You use twice your sodium plus glucose plus BUN. And you can just add everything if this is in millimoles per liter. But if we are using milligrams per deciliter, you need to convert your glucose and BUN into millimoles per liter by dividing glucose by 18 and BUN by 2.8. So it is said that you have an elevated osmolar gap if the difference between your measured and your calculated exceeds 10 to 15 millimole per kilogram water. So an increase in osmolar gap more often than not indicates the presence of other osmolytes aside from your sodium, glucose, and BUN. So it could be alcohols. Okay. Going back to our case, the measured osmolality is 365, whereas our computed osmolality, if you compute for it using the formula, it's 294. We have a gap of 71. So we have a patient with a high gap acidosis with an elevated osmolar gap, with a history which is not suggestive of a lactic acidosis or a ketoacidosis. We are now considering alcohol ingestions. Now, fatal intoxications are caused by these three alcohols, which all cause an elevated osmolar gap, but only ethylene glycol and methanol cause a high gap acidosis. Your isopropyl alcohol, your rubbing alcohol, is metabolized into acetone, which is rapidly excreted. That's why the anion gap is normal. Okay. Now, ethylene glycol is used in your coolants or your antifreeze for your cars. And ingestion of this leads to a high gap acidosis with an increase in osmolar gap. Now, the cause of the high gap acidosis is because of its metabolites, the glycolic acid, oxalic acid, and there may also be lactic acid formation. In this type of toxicity, ethylene glycol induced, there is a predominance of neurologic symptoms initially, which explains the presentation of our patient. But after 12 hours, the pulmonary edema and tachypnea occur, and then renal failure is a late sign. So our patient seems he's okay, right? Because he presented to us around 2 hours after the supposed ingestion. But if he were to present to us more than 12 hours after, his presentation would be drastically different. Okay, that's why whenever you suspect a patient with ethylene glycol toxicity, you have to you shall not delay and you should give your treatment. So a clue to its diagnosis is the oxalate crystals on urine microscopy. Okay. So how do you manage this patient? You have to do prompt saline or osmotic diuresis. This is so that the oxalate crystals do not clog up or obstruct your renal tubules, and that's the one that causes renal failure. You give thiamine and pyridoxine because this prevents the formation of your oxalic acid. So we're all about preventing the metabolite production. Next, the drug of choice is fomepizole, which is an alcohol dehydrogenase inhibitor. Alcohol dehydrogenase acts on your ethylene glycol, and this is what causes the formation of your toxic metabolites. Fomepizole competes with ethylene glycol for its metabolism. Okay. Now, if you don't have fomepizole, you can use ethanol, IV, because this does the same thing. And in the case of acidosis and an elevated osmolar gap of more than 20, you can do hemodialysis, which can it can remove both the parent compound and the metabolites. Okay, so going back to the case, this is how you're going to manage this patient. Okay, next, methanol-induced acidosis. Now, methanol toxicity is characterized by severe optic nerve and CNS damage. These patients, they go blind before they die, and that is because of formaldehyde and formic acid. I don't know if you remember, if anyone remembers back in 2019 when a number of people went blind and then died because they consumed Cosmic Carabao, which is a local gin. Well, the gin was found to have high levels of methanol when they investigated. So prompt treatment with fomepizole and hemodialysis are needed in this case. Okay, so just like ethylene glycol, it is because of the action of alcohol dehydrogenase that toxic metabolites are produced, formaldehyde and formic acid. So we give either IV ethanol or fomepizole to prevent this from occurring. Okay. Next, propylene glycol. It is the vehicle used in the IV administration of your diazepam, lorazepam, phenobarb, and etc. So a typical patient is in the ICU on continuous therapy with either of these drugs. So consider this diagnosis in a patient with an unexplained high gap acidosis and hyperosmolality because this raises the anion gap, and then clinical deterioration, and the patient is also on treatment for alcohol withdrawal because diazepam is often given to patients in alcohol withdrawal. Now the management includes stopping the medication and giving fomepizole. So that's three alcohols that to which we give fomepizole, for which we give fomepizole: methanol, ethylene glycol, and propylene glycol. Okay, so in isopropyl alcohol ingestion, it is the parent compound that causes the toxicity and not its metabolite. Its metabolite is acetone, which is rapidly excreted. So there is often no anion gap acidosis as mentioned, but you will find an elevated osmolar gap and hypoglycemia. Now, treatment here is supportive, and you can do hemodialysis if the patient is hemodynamically unstable. And this occurs when the plasma levels of isopropyl alcohol reach more than 400 milligrams per DL. Okay, next, we have oxoproline or pyroglutamic acid. This accumulates in acetaminophen toxicity because of depletion of your glutathione stores. So we consider this uncommon cause in ill patients taking acetaminophen with unexplained high gap acidosis and a normal osmolar gap. So our management is to stop the acetaminophen and give sodium bicarbonate. Now, toxic levels of aspirin can increase the salicylic acid in our blood and saturates the enzyme that's responsible for its metabolism. Aspirin toxicity is characterized by two acid-base disorders. As mentioned a while ago, we have a high gap acidosis and a respiratory alkalosis. How can you manage these patients? So first, you have to prevent the absorption of aspirin that's already in the gut. You do this by gastric lavage and administering activated charcoal via NGT. And then also you need to alkalinize the urine and the plasma to increase its renal clearance. You give sodium bicarbonate IV, and we can also do hemodialysis. Now, given a case, 31-year-old male with a history of epilepsy and grand mal seizure, laboratory tests taken immediately after the seizure has stopped revealed the following. Okay, so given a case with just these lab results, you're going to have to assume that the ABG and the electrolytes were taken simultaneously. First, the pH is low and acidemia, bicarbonate is low, consistent with the metabolic acidosis. Let's use the Winter's equation. 1.5 times 17 plus 8 plus minus 2 gives you 31.5 to 35.5. Our patient's PCO2 is much higher at 45. So we have an acute respiratory acidosis with the metabolic acidosis, which is understandable since the patient just had a grand mal seizure. And during that time, must have had hypoxia. Now, the anion gap is 140. Sodium minus chloride of 102 plus 17, we have a 21, a high gap acidosis. And when we do the delta-delta calculation, we have a value of 1.5, which is a pure high gap acidosis. So this patient has a high gap acidosis and respiratory acidosis. The high gap acidosis is from the lactic acidosis that developed because of the seizure. There are two types of lactic acidosis. We have type A and type B L-lactic acidosis. Type A is caused by conditions that induce tissue hypoxia because in these cases, oxidative phosphorylation cannot occur, and so pyruvate gets converted to lactic acid. Now, so this is a table I got from Brenner, but these were also enumerated in Harrison's. Okay, so mostly shock and hypoperfusion and hypoxia. Okay, so type B lactic acidosis, they're not caused by tissue hypoxia. However, these conditions have in common either decreased lactate consumption or an impaired lactate removal. So liver disease, down the line. Seizure belongs to type B lactic acidosis. Again, this is from Brenner's. Okay, so management of L-lactic acidosis involves treatment of the underlying condition or cause. So we need to restore tissue perfusion, And that is through usually volume resuscitation with IV fluids. And then we give alkali therapy when the acidosis is severe. The goal is to return the pH back to 7.2 or a bicarbonate of 12. So the goal is never to bring the pH or bicarbonate to normal because of the common complications of alkali therapy. It can cause paradoxic depression of cardiac performance. It can paradoxically enhance your lactate, can cause fluid overload and hypertension because your sodium bicarb solution is a very hypertonic solution, and it can even cause overshoot alkalosis. So going back to our patient with a grand mal seizure, do we give sodium bicarb? What do you think? Look at the pH 7.14, bicarbonate is 17. But we need to consider the case. If the seizure stops, all the lactic acid that was formed or produced during the seizure gets metabolized to bicarbonate. So no, we do not have to give sodium bicarb to that patient. We need to control the seizure and figure out what triggered it. Okay? Sige. Next, we have D-lactic acidosis. So what is D-lactic acid? It is produced by bacteria. And the only way we can develop this acidosis is if we have a short bowel or if we have an intestinal obstruction. Because patients with shortened small intestines are unable to fully absorb the dietary sugars in the diet. Dietary sugars. So the carbs will be metabolized by the bacteria in the colon. And this presents as a metabolic acidosis that occurs after meals associated with neurologic changes. So the patient is confused, has slurred speech, has loss of memory, and even ataxia. So patients with a waxing and waning neurologic change and waxing and waning high gap acidosis probably have D-lactic acidosis. And the treatment involves antibiotics and a low carb diet. Okay, we have a third case, a 32-year-old male with type 1 DM presenting at the emergency room with drowsiness, fever, cough, diffuse abdominal pain, and vomiting. So the fever and cough started 2 days ago, and the patient developed anorexia. And before this, he had an intensive insulin regimen prior to this event. So at the ER, he's confused, tachypnic, febrile, tachycardic, and has a supine BP that's low normal, 100/70. On PE, he has signs of volume depletion. So we have the following lab results. Okay, the patient has hyperglycemia, he has ketosis, he has signs of sepsis, WBC is 18, probably from the pneumonia, and he is dehydrated with an elevated sodium, a urine-specific gravity that's high, and that's probably from the glycosuria and osmotic diuresis that occurred. Okay, and look at the pH. Sige, let's tackle the ABG. Now, using the Winter's equation, so we already know that the patient has a metabolic acidosis because the pH is 6.9 and bicarbonate is 5. Our expected PCO2 is 13.5 to 17.5. Our patient's PCO2 is 28, much higher, telling us that the patient has a respiratory acidosis as well as a metabolic acidosis. Now, an ion gap is 37. This is a high gap acidosis. And our delta, so 37 is the anion gap minus the normal anion gap of 10 over 24 minus 17, which is the patient's. I'm sorry, this is not 17, but this is 5. And we get, wait, let me check that, okay? 24 minus 19, 37 minus 10. So I'm sorry, this is not 3.85 because this is not supposed to be 17. This is 5. Okay, we get a value of around 1.4, so that's a pure high gap acidosis. Okay, the high gap acidosis is from the DKA. He does not have metabolic alkalosis, and the respiratory acidosis is from the pneumonia. So my apologies, this is not accurate. This 17 here is supposed to be 5. And so the delta is not 3. Okay. Okay, let's talk about ketoacidosis. Remember that ketones are produced when glucose is unavailable for metabolism. It occurs in 3 scenarios: in diabetic ketoacidosis, in starvation, and alcohol ingestion. Now, DKA usually occurs in insulin-dependent DM or type 1 DM when there is an absolute or relative lack of insulin. The patient's glucose levels are often more than 300, and because of the glycosuria, there is polyuria, polydipsia, hypovolemia with mental status changes, and an anion gap metabolic acidosis and Kussmaul's respiration. So these patients are very, very sick. And treatment involves insulin, most importantly, fluid resuscitation, and alkali therapy is rarely needed. So the insulin is required to stop to correct the hyperglycemia and to stop the ketogenesis. Now, the endpoint of insulin administration is not a normal glucose. In fact, we even switched the IVF to a D5 containing one in order that we can continue our insulin administration because our goal is a normal anion gap. Okay, so volume replacement is essential to replace the fluid loss due to the osmotic diuresis from the glycosuria. And often these patients have a large potassium deficit. Even if, look at our patient, he has a potassium of 5.3. However, that is because the hyperosmolality from the hyperglycemia, it shifts the potassium out of the cells into the blood. So when you administer insulin and your fluids, this potassium level is going to drop and you might need to supplement potassium. And then finally, alkali therapy is rarely needed because usually with insulin therapy, everything normalizes. Okay, so next we have alcoholic ketoacidosis.
Here.
It's characterized by increase in plasma ketones, alcohol ingestion, and malnutrition. Now, how does chronic excessive alcohol consumption predispose to ketone production? First, these patients, these alcoholics, don't usually eat, they just drink alcohol, so the body shifts the fuel from glucose to ketones. And then alcohol itself stimulates lipolysis. Now, this is often associated with mixed acid-base disorders. So take a look here. Because of the vomiting, these patients also develop a metabolic alkalosis. Because of the alcoholic liver disease, there's also respiratory alkalosis. And hypoperfusion causes lactic acidosis in addition to the ketoacidosis. Okay? So as opposed to your DKA, the glucose levels here are less than 150, and it's because of this relative hypoglycemia that inhibits insulin release. So that allows the ketosis to occur. So you have to provide glucose and fluids in the form of a D5 NSS, and then correct the electrolyte abnormalities that are often found in these patients, hypokalemia, and hypomagnesemia. Finally, our fourth fundamental cause of high gap acidosis is renal failure. So with advanced kidney failure, the daily hydrogen load and the accompanying anions are not fully excreted because of the reduced glomerular filtration rate. Bicarbonate is not replaced, and that causes the metabolic acidosis. So initially in CKD stage 3, the reduced number of nephrons, they produce more bicarbonate to compensate. So initially we have a non-gap acidosis. However, as the number of nephrons decrease and your GFR further declines, the filtration of the daily acid load also decreases, and there is now a reduced rate of ammonium production and excretion, which raises your anion gap. So that's why even at CKD stage 3 at a non-gap acidosis, we need to give alkali replacement therapy to maintain our bicarbonate level at normal of 25. This usually requires 1 to 1.5 millimole per kilogram per day. So you can give your sodium bicarbonate tabs, your 650 milligram per tab, which contain around 7.8 milliequivalents per tab. So if you have a 50 kilogram patient, you're going to need about 6 tablets a day. Okay, so that's it for high gap acidosis. Let's proceed to non-gap acidosis. This type of acidosis is due to the loss of bicarbonate from either the GI tract or the kidney. Now, the loss of bicarbonate results in an increase in hydrogen ion and an increase in chloride concentration to maintain electron neutrality as mentioned. And because of this, there's a normal anion gap. As you can see, all GI tract secretions below the stomach are rich in bicarbonate, so that any process that increase lower GI fluid loss can cause a non-gap acidosis. And diarrhea is the most common cause. So you have to understand that our colonic mucosal epithelia have a chloride bicarbonate exchanger, so that when stool passes, chloride from stool is reabsorbed and bicarbonate is excreted. So we lose bicarbonate in our stools. However, with a normal bowel movement, this is easily replaced by our kidneys. But in diarrhea, the kidneys cannot keep up. That's why we have non-gap acidosis. The management is to give sodium bicarbonate, either IV or PO. Okay. So in non-gap acidosis, you need your urine and ion gap to distinguish between a GI loss or a renal loss of bicarbonate. Now, in metabolic acidosis, if you have normal kidneys, your kidneys excrete ammonium if its renal acidification mechanism is intact. So when your ammonium increases, see, the normal response is to increase urine ammonium, your urine chloride also increases because it gets excreted as ammonium chloride. That is again to maintain electron neutrality. So using this formula, urine sodium plus urine potassium minus urine chloride, if you have intact renal acidification mechanism, your urine chloride increases, you get a negative urine and ion gap. So if your urine and ion gap is negative, you have probably a GI loss because your kidneys are able to compensate. However, if there's a problem in your kidney acidification mechanism, your urine chloride is unable to increase because your urine ammonium is unable to increase. So you get a positive urine and ion gap. And so this tells us that the cause of the acidosis is probably renal. Okay, so renal tubular acidosis is a loss of bicarbonate due to a renal defect. Now, all RTAs are characterized by a defect in bicarbonate resorption or in hydrogen excretion. The RTAs are characterized or categorized according to the location or the type of defect. So, proximal RTA, distal RTA. Remember that renal regulation of bicarbonate occurs in these two steps, as we mentioned at the start. Okay. Let's start with proximal RTA. It is known as the type 2 RTA. There is a decrease in bicarbonate reabsorption in our proximal tubule. So this is our proximal tubule cell. This is the lumen. And here we have transporters here. So proximal RTA, the reduction in bicarbonate reabsorption can either be an isolated defect, meaning there is nothing else wrong with our proximal tubule, or it is a part of a generalized defect in Fanconi syndrome, which manifests as a glycosuria, amino aciduria, and phosphaturia. Because remember that glucose, phosphates, and amino acids are reabsorbed in our proximal tubule along with the sodium. It's a sodium-coupled transport. Okay, so in proximal RTA, there is a reduction in the total bicarbonate reabsorptive capacity. What happens is, because of the defect in bicarbonate reabsorption, there is bicarbonaturia because the amount of bicarbonate delivered to the distal nephron is too much for the distal nephron to reabsorb. So you pee bicarbonate. And because of the bicarbonaturia, there is an extracellular fluid volume contraction, which which stimulates enhanced chloride reabsorption, leading to the non-gap acidosis or hyperchloremic acidosis. Now, both the acidosis and your bicarbonaturia, they eventually deplete or reduce your serum bicarbonate levels in your blood. Now, because your bicarbonate level has reduced from a normal of, let's say, 26, it has now become 20 or 15, there is a decline in the filtered bicarbonate load. Now, the amount that enters your tubules is now an amount that the distal nephron is able to reabsorb. Okay, did you get that? So now there is a complete distal reabsorption of bicarbonate, and that is how your pH in the urine is less than 5.5 because all of the bicarbonate is now being absorbed by the distal nephron. Okay. However, because the treatment is to give bicarbonate replacement and your patient is not still able to reabsorb a higher level of bicarbonate that enters the filtrate, the bicarbonate that you administer is going to spill over into the distal nephron, and now it becomes an amount that the distal nephron is not able to reabsorb. And so bicarbonaturia again happens during the management of proximal RTA. And because of the bicarbonaturia, there is also kaluresis or the excretion of potassium in our in our urine. And so that causes a hypokalemia. And this is why proximal RTA is very challenging to treat, because as you correct your acidosis, you induce hypokalemia. You actually need around 10 to 20 milliequivalents of bicarbonate per kilogram in order to bring your bicarbonate level to a normal level. However, there is a strike through here because this is not our aim in adults. This is only for children with proximal RTA so that they can grow normally. But in adults, do not aim for the normal because you're just going to suffer with a hypokalemia. Okay. So you can give actually potassium citrate because it hits two birds with one stone. You get potassium and then the citrate gets metabolized to bicarbonate in your body. Okay, by the way, there are drugs that can induce a form of proximal RTA, and these are your acetazolamide and your topiramate. So acetazolamide is a diuretic and your topiramate is an anticonvulsant, and both of them inhibit your carbonic anhydrase in the proximal tubule, and they cause bicarbonate wasting. So that's how they induce proximal RTA. Okay, in classic distal RTA or type 1 RTA, there is an inability to acidify the urine. So there's a defect that prevents the complete excretion of your daily acid load. So this is your H-ATPase transporter in your intercalated cell in the distal nephron. Okay, it no longer functions so that hydrogen ions cannot be secreted into the lumen. And so bicarbonate cannot be generated. This is how the acidosis is develops. In these patients, there is a non-gap acidosis, there is a hypokalemia, a low urine ammonium, because the low urine ammonium is because hydrogen here is no longer available to bind to the ammonia that was produced. Okay, so these patients often have bone disease because unlike in proximal RTA, wherein when the bicarbonate drops to a nadir of about 20, it just stays there because the distal nephron is now able to reabsorb the bicarbonate. In classic distal, it is a progressive acidosis because we keep introducing, because of the diet and metabolism, the daily acid load compounds and the acid accumulates. So because we have a lack of bicarbonate, what buffers the acid is our bones. So now that there's an excess calcium and phosphate in our urine because of the breakdown of the bones, we can have nephrolithiasis in these patients and nephrocalcinosis as well. Okay, so how do we manage these patients? Acutely, we have to deal with the hypokalemia, so we give potassium replacement. And we also give bicarbonate. However, the dose is very, very much achievable at 1 to 4 milliequivalents per kilogram per day. So this is easier to treat. Our goal in distal RTA is a normal bicarbonate level. Okay, so type 4 RTA refers to metabolic acidosis from aldosterone deficiency or resistance. So remember that if we are hypoaldosterone, we have hypoaldosteronism, we often have hyperkalemia because the aldosterone stimulates your epithelial sodium channel. Okay, it's not here. The epithelial sodium channel is stimulated, so sodium gets reabsorbed. And because of the lumen negative potential, potassium gets excreted. So that's what occurs when aldosterone is present. Now, these patients are hyperkalemic because of the hypoaldosteronism. And hyperkalemia decreases ammoniogenesis. So remember that ammonia is the only way that the kidneys can compensate for the acid load, the increasing acid load by increasing hydrogen excretion. It's through the ammonium excretion. And so there is the causes of generalized distal RTA are DM nephropathy, obstructive uropathy, and chronic tubular interstitial disease. So how do we manage these? We have to treat the underlying disorder and to correct the hyperkalemia. Once we correct the hyperkalemia, the ammoniogenesis improves and acidosis improves as well. So how do we correct the hyperkalemia? We can prescribe a low potassium diet. We can give loop diuretics. We can discontinue all the potassium containing and potassium sparing medication. We can also give them the sodium polystyrene sulfonate, the potassium resin, and then that's it. So the goal is to correct hyperkalemia. To summarize, these are your renal tubular acidosis, proximal, classic distal, and generalized distal. Hypokalemia in proximal and classic distal, but hyperkalemia in type 4. Urine pH is less than 5.5 in proximal, more than 5.5 in distal, and either in generalized distal. And then least responsive is proximal, as mentioned. And we get Fanconi syndrome in proximal, nephrocalcinosis and nephrolithiasis in classic distal. Renal insufficiency is common in distal dysfunction. And our treatment, more onto control hyperkalemia in generalized distal. Okay? Sige. So these drugs were identified as drugs that cause hyporeninemic hypoaldosteronism in our patients, which causes hyperkalemia, which again causes acidosis. Now, these drugs cause hyperkalemia mostly due to a reduction in aldosterone activity and as an effect, a decrease in the net acid excretion. So amiloride and triamterene, these inhibit your epithelial sodium channel, so sodium cannot be reabsorbed. And because of the lack of the lumen negative potential, potassium is not excreted. So they have the same mechanism with trimethoprim and pentamidine. Now, spironolactone and eplerenone, they inhibit your mineralocorticoid receptor so that there is an aldosterone activity reduction, and so it still affects your ENaC and ROMK. ACE and ARBs, they reduce your levels of aldosterone in the blood in their own ways by either blocking the angiotensin receptor or by the enzyme that converts angiotensinogen to angiotensin 1 to 2. And then your NSAIDs, they reduce the production of your renin, and down the line also reduce aldosterone production. Heparin. Heparin inhibits your aldosterone synthase in your critically ill patients. And your calcineurin inhibitors, these are drugs that are commonly used in your kidney transplant patients to prevent graft rejection. So these cause acidosis by tubular injury and by hyperkalemia because it blocks the ROMK. So potassium is not secreted into the lumen. Okay, so general principles of management for metabolic acidosis. Alkali therapy should be reserved for severe acidemia. So, however, if we have no potential bicarbonate in plasma, we can give alkali therapy. So what does that mean? In non-GAP acidosis, as in diarrhea or RTA, or in acidosis from renal failure, we need to give alkali therapy because the potential bicarbonate is only present if our acid and ion that's accumulating in our body are metabolizable. So they are in the forms of beta-hydroxybutyrate, acetoacetate, and lactate. Okay, so how do you estimate? You solve for the delta anion gap, which is the patient's anion gap minus 10. In these cases, as you notice, these are all keto acids and lactic acid. So in the case of ketoacidosis and lactic acidosis, we have potential bicarbonate because when the process that induced the acidosis is resolved, all the beta hydroxybutyrate and the lactate that has been accumulating will be metabolized back into bicarbonate. Okay, that's why we reserve alkali therapy for severe acidemia only, because we will be affecting an overshoot alkalosis. However, in CKD or toxin ingestion, the anions that accumulate are non-metabolizable. So these are not potential bicarbonate. That's why we can give alkali therapy in these patients. Okay. Now, going back to ketoacidosis and lactic acidosis, the use of alkali therapy is controversial. However, that's why we say if the pH is less than 7.1, then you can consider giving it, especially in your elderly patients with severe heart disease. So you can give it by 50 milliequivalents of sodium bicarb in 300 ml D5 water IV over like an hour. However, we need to monitor plasma potassium because hypokalemia develops during bicarbonate administration. And the goal here is to increase pH only up to 7.2 and bicarbonate to 10 to 12. Okay. Sige. So that's it for metabolic acidosis. Let's move on to metabolic alkalosis. This is characterized by an increase in plasma bicarbonate and a pH. And after buffering and respiratory compensation, PCO2 is also increased. And this is often associated with hypochloremia and hypokalemia. Now, this is a two-step process. There is a generation stage and a maintenance stage. In the generation stage, we ask, what is the source of the alkali gain or the acid loss? Is it that we added bicarbonate by giving sodium bicarbonate? Or is it contraction alkalosis in the case of vomiting? Or is it loss of hydrogen, either extrarenally, as in vomiting again, or renally, as in the use of diuretics? In the maintenance stage, we ask, what renal mechanisms are operating to prevent excretion of the excess bicarbonate that has been generated? So there are usually just two. It's either that the patient is volume depleted, which is accompanied by chloride and potassium deficiency and a reduced GFR, or the patient has an autonomous hyperaldosteronism that is often associated with potassium deficiency. Now, if it's the first problem, we can just give KCl and sodium chloride. But if it's the second problem, you might need to give pharmacologic agents or have to manage surgically, as in the case of an adrenal adenoma. So let's discuss. First, let's understand that if we have an excess mineralocorticoid activity or a hyperaldosteronism, there is increase in hydrogen ion excretion. So how does this happen? Aldosterone directly increases the activity of our HATPase in our intercalated cells, so hydrogen gets secreted into the lumen. And indirectly, aldosterone does this by stimulating your ENaC, so sodium gets reabsorbed, the lumen is now electronegative, so potassium is excreted to maintain electroneutrality, and hydrogen is also secreted. Okay, I hope this is clear. Next, how does hypokalemia maintain metabolic alkalosis? So remember that in our intercalated cells, we have the HK-ATPase. In hypokalemia, potassium is reabsorbed. And at the expense of hydrogen, hydrogen gets pumped out. So that's how it causes alkalosis. Another way is that hypokalemia increases ammoniogenesis. Remember, hyperkalemia decreases ammoniogenesis, hypokalemia increases ammoniogenesis. So if our kidneys are excreting hydrogen in the form of ammonium, that leads to metabolic alkalosis. To establish the cause of metabolic alkalosis, we need to assess the patient's volume status, serum potassium, and in some cases, our renin and aldosterone levels. So why is volume status an important qualifier? We mentioned a while ago that hyperaldosteronism leads to the maintenance of metabolic alkalosis. Now, hyperaldosteronism can either be primary, in which case the patient is hypervolemic as an effect, or the patient can be hypovolemic, in which case the hyperaldosteronism is secondary to the hypovolemia. Okay. The first group of causes of metabolic alkalosis is exogenous bicarbonate loads. So this can be either in the form of sodium bicarb treatment. Your citrate loads are through massive blood transfusion or apheresis, and then enteral tube feedings contain a large amount of acetate. So acetate and citrate, they get metabolized to form bicarbonate in our body. Now, in milk alkali syndrome, the chronic ingestion of calcium-containing antacids, they cause hypercalcemia, and that induces polyuria and volume depletion. And remember, volume depletion causes and maintains metabolic alkalosis. And the antacids themselves, they contain bicarbonate. Okay, we can easily identify this cause through a clear history taking. Next, our next group is characterized by extracellular volume contraction, normotension, potassium deficiency, and because of the contraction of our ECF, there is compensatory hypereninemic hyperaldosteronism. Okay, first, vomiting. It can result in both generation and maintenance of metabolic alkalosis. It generates alkalosis because of the hydrogen that's lost. Because remember, our chief cells, they produce hydrogen chloride. So hydrogen gets lost as we vomit, and that is equivalent to bicarbonate gained, diba? And then also contraction alkalosis. The fluids that we lose are bicarbonate poor. So the fluids that's left in our body contracts around bicarbonate level. So the concentration of bicarbonate increases. So that's how alkalosis develops. Now, how is it maintained? If we vomit incessantly, we develop hypovolemia. The hypovolemia stimulates an excess mineralocorticoid activity. There is an increase in aldosterone activity, and this causes hypokalemia. So these three, which are linked together, each of them cause maintenance of the alkalosis. Okay. So the treatment here is to give IV NSS. Next, diuretics. So our loop and thiazide diuretics, they acutely diminish our extracellular fluid volume without altering the total body bicarbonate content, so it causes contraction alkalosis. And then how do they increase hydrogen ion loss? Because of the diuretics, there's an increase in distal solute delivery in our distal nephron. So this is the distal nephron. Because of the increased sodium delivery here, sodium gets reabsorbed by our ENaC, and again, potassium is excreted and hydrogen is also secreted to maintain electroneutrality. So that is how hydrogen ion loss occurs. Now, how does it maintain? It's still through hypovolemia, secondary hyperaldosteronism, and hypokalemia. And the treatment is to stop the diuretic and give IV NSS. Okay. Post-hypercapnia is a state of persistent metabolic alkalosis after the return of PCO2 into baseline. So these patients usually have COPD, they have chronic respiratory acidosis. And then when they get ill, like with a pneumonia, they are intubated. When they're intubated and ventilated, the PCO2 rapidly decreases. However, their bicarbonate was already increased to begin with because the kidney has been compensating for the respiratory acidosis. But when the PCO2 drops, the bicarbonate cannot drop as rapidly. So that's how post-hypercapnia develops. Now, in lactic acidosis or ketoacidosis, after the event that caused the acidosis, all the lactate or keto acids that have accumulated can be metabolized into bicarbonate. So that is how they are potential bicarbonates, remember? So for post-hypercapnia, we should remember never to rapidly reduce PCO2 and to provide enough chloride and potassium so that the excess bicarbonate levels in our body can be excreted. Next, for the lactic acidosis and ketoacidosis overshoot alkalosis, we just have to remember never to give bicarbonate to target a normal pH or bicarbonate level because of the potential bicarbonate in organic acids or anions. Okay. Next, we have non-reabsorbable anions in the form of penicillin, ticarcillin, and carbonicillin. These anions, they increase the transepithelial potential difference across the collecting tubule. So they enhance hydrogen and potassium secretion. That's how they cause metabolic alkalosis. In hypomagnesemia, the low magnesium causes renin release, increases aldosterone, which increases distal hydrogen secretion as we discussed. And milk alkali syndrome has already been discussed. Okay, so I know that Dr. Revillas discussed on Barter's and Gitelman syndrome. Just a review, they are the two major variants of your familial hypokalemic alkalosis. They are autosomal recessively inherited, and they are both characterized by solute loss because of a defect in transporters. So in Barter's, the defect could be in the sodium potassium 2 chloride cotransporter or the potassium channel or the chloride channel subunit. So there are five subtypes, but the point is that the patients lose these solutes, your sodium, potassium, and chloride. And then in our Gitelman syndrome, there is an inactivation of your sodium chloride cotransporter in the distal tubule. So in both these conditions, because of the solute loss, there is an extracellular fluid volume contraction, and this stimulates renin and aldosterone release, which enhances again hydrogen secretion. Okay. So these next group of patients have high aldosterone levels to begin with. That's why they are volume expanded, and that's why they're hypertensive, and that's why they're hypokalemic. However, those conditions that are characterized by a high renin are the following. Now, in renal artery stenosis, there is a stenosis in your renal artery, meaning the perfusion to your kidneys are reduced. And so these are sensed by your kidneys, and this causes compensatory increase in renin, which leads to an increase in aldosterone. So that's how this occurs. In accelerated hypertension or malignant hypertension, there is ischemia, renal ischemia, which again stimulates renin and aldosterone release. Renin secreting tumor is self-explanatory. Your estrogen therapy, estrogen increases the level of angiotensin in your blood. Angiotensin leads to aldosterone release. Now, in your low renin conditions, the renin here is low because it is feedback inhibited by the conditions that cause aldosteronism by themselves, such as in the case of an adrenal adenoma, hyperplasia, or carcinoma. And also in congenital adrenal hyperplasia, there is a defect in the production of cortisol, but there is an accumulation of mineralocorticoid precursors. And these are the ones that cause the excess mineralocorticoid activity. Next, Cushing's disease, due to an adenoma in our anterior pituitary gland, it produces ACTH, and the ACTH again stimulates the production of aldosterone. Okay, let's discuss licorice. So, you have to understand that the mineralocorticoid receptor here, MR, has equivalent affinity for both aldosterone and cortisol. But the reason that it is protected from illicit activation by cortisol is because of the presence of our enzyme 11-beta hydroxysteroid dehydrogenase 2. This converts cortisol into cortisone. And then cortisone now is unable to activate your MR. Okay? Now, licorice has glycyrrhetinic acid. This inhibits your enzyme so that cortisol cannot be converted to cortisone, and therefore cortisol is now able to act on your mineralocorticoid receptor. So its effects are as if your aldosterone levels are high. Okay, so you lose potassium, you lose hydrogen, you have alkalosis, you have hypokalemia, and you also have sodium reabsorption. That's why your patient is expanded and hypertensive. Now, carbenoxolone was used before to treat peptic ulcer disease. It also contains glycyrrhetinic acid, and Chewer's tobacco contains the same substance. Okay. Liddle syndrome. Now, this is autosomal dominantly inherited condition in which there is a gain of function mutation in our epithelial sodium channel of our connecting tubule and cortical collecting duct. The increase in activity in our sodium channels results in a lumen-negative potential, and this results in potassium excretion and also hydrogen secretion. That's why these patients, they are hypertensive here because of the sodium reabsorption. They are hypokalemic because of the potassium secretion, and they are alkalotic. Okay. And they have low renin and aldosterone because of the volume expansion that occurred because of this mutation right here. Okay. So the manifestations of your metabolic alkalosis are similar to those of hypocalcemia: mental confusion, obtundation, some paresthesias, and arrhythmias. Now, how do we treat metabolic alkalosis? We correct the stimulus. Whatever that caused the generation of bicarbonate, we correct it. And whatever that's sustaining the inappropriate increase in bicarbonate reabsorption, we correct that as well. So often it's volume depletion or potassium deficiency. So we need to make sure that we give enough sodium chloride. But however, in some cases, our patients are volume, they cannot tolerate sodium chloride, like in congestive heart failure. So we can give acetazolamide, which causes an excretion of your bicarbonate. However, be careful, but because this can cause metabolic acidosis. Okay. Okay, so that's it. Respiratory acidosis is characterized by an increase in PCO2, which causes a drop in pH, and our kidneys compensate by increasing bicarbonate reabsorption. Just very briefly, I'm just going to flash you this table that's on Harrison's. So the increased CO2 is always the result of inadequate ventilation, which can be a central airway, parenchymal, neuromuscular cause. And then the treatment is just to restore adequate ventilation through maybe assisted ventilation. You can intubate your patient or you attach him to a non-invasive ventilation. Remember that you need to judiciously use oxygen in your COPD patients to prevent worsening hypercarbia. And do not ever rapidly decrease PCO2 because it can provoke seizures, arrhythmias, and it can reduce cerebral perfusion. Okay, that's it. Respiratory alkalosis is a drop in PCO2 causing a rise in pH, and the kidneys compensate by reducing bicarbonate reabsorption. And these are the causes. It is always because of hyperventilation for these reasons, and the treatment is to alleviate the underlying disorder. Okay, so I'm done. I'm sorry. It's past 3. If you have any questions for me, I will try to answer them. Okay, so you can unmute your mics.
Doc, I have one question. I think sa Delta Delta,
Mm,
I think there
yes.
was one case na, di ba ang ideal was 24, then PCO2, I wait, bicarbonate.
Okay, wait ha. I'll go. Um, and then,
Then ang ihang measured nga bicarbonate doc was 25. Ang ako nga question doc if is amo bang i-omit lang ang negative kay 24 man
yes,
yun?
yes. I-omit mo ang negative.
Okay, sige. No,
Oh, wait ha. Bitaw, sakto ka. Yes, because we're dealing with delta. So, dapat siya, wala tay signs, wala plus, minus. We just need to know the difference in both. So if you're saying, what if 25 ang bicarbonate sa patient and then atong normal? Actually, no. Kung 25 yung bicarbonate, you can just, whether you ka mo saying normal yung bicarbonate because 25 is normal. So, whether sa di mo 25 minus 25, so 0, ingana. Okay, so we're not so strict with that, good. Did I flash up, kuan ba, example na 25? Is
yes.
it this one?
Okay.
Okay. So in this case, what I did, give minus na ko ang 24 from 25. However, this can also be 0, in which case, dili na siya mahimo og 20 divided by 0, mahimo og 0 ha, dili nga na. Kuan siya, just make it 1 na lang para easier, para simpler. Ang point is, the anion gap, delta anion gap is much higher than the delta bicarbonate. So, I guess in this case, if it's over 0, you dili siya 0 ang answer, but you take the numerator na lang, okay? Was that clear, Ra?
Yes, doc.
Okay, sige. Kiba ko medyo libog ni, but as you do this, when every time you get an ABG and you apply all the steps, kaya you get the hang of it and maana drug yun mo. Okay, are there any other questions? Sige. So, did you learn, naay ba yung mga points during confused mo about? I hope that I was able to explain during the time that is allotted.
Information overload lang din, doc. Kaya it's a very long and complicated.
Yes, I understand. Even ako, naglisod ko og fit sa akong lecture. We're going over na guys sa time, but I just want to say nga, it's very, very difficult to even discuss it in this short amount of time. So I can understand that it's just too much information no, to take in. But this was so, makahelp siya sa inyong readings. Naka-supplement lang po gamay. It just brings everything together, I hope. Okay, so if there are no other questions, we can end this so you can read on the topic na. Okay.
Thank you so much, doc, for the lecture.
Thank you, Doc.
Okay, thank you, Sad. You're welcome.
Thank you, Doc.
Bye-bye.
Thank you, Doc.
Thank you so much, Doc.
Bye. I'll see you
Thank
2
you,
weeks from now.
Doc.
Mag-discuss na po ta on glomerular
Doc.
diseases. Okay,
Thank you,
bye-bye.
Doc.
Thank you.
Okay, Doc. Thank you, Doc.
Okay.
Thank you, Doc.
Thank you, Doc.
Bye-bye.